The Profit of Death: How Wall Street Took Over Senior Care. The door was locked from the outside. The call light blinked for 23 minutes. No one came. By the time the family reached the hallway, the door was locked from the outside, and a lone aide juggled 3 alarms. An ambulance was called, then canceled, then called again. It arrived too late. Months earlier, this facility had quietly changed hands. The new owners never put their name on the front sign. Bills were paid, schedules tightened, paperwork ballooned. The family kept asking who was in charge. Nobody would say. To understand why those minutes vanished, we have to rewind to the moment Wall Street noticed a business hiding in plain sight. The Buyout Playbook begins. It starts with a spreadsheet. On one side, 15,000 nursing homes spread across the country, many small, many struggling, most dependent on predictable checks from Medicare and Medicaid. On the other, a decade of cheap debt, fund managers under pressure to deliver double-digit returns, and an industry that looks fragmented enough to roll up. The pitch is clean. Nursing homes serve a growing, aging population. Demand is steady. Payers are mostly public, which means cash flows arrive, even when the economy dips. There's also real estate, the land and buildings, assets you can finance, sell, and lease back. For a fund, that means 2 levers: operations and property. If you can buy a cluster of homes, centralize back-office functions, negotiate supply contracts, and load the acquisition with low-interest debt, the numbers say you can extract more cash, faster, than a mom-and-pop owner ever could. This is where incentives diverge from lives. Private equity funds are built around internal rates of return and short holding periods. The clock starts the day they buy. Every quarter, the investment has to show progress. Higher margins, cleaner financials, a path to exit. But nursing homes are slow, human businesses. Outcomes show up in months, sometimes years. The daily work, bathing, turning, monitoring, listening, doesn't automate. It takes people. So the roll-up model adapts the sector to the fund, not the other way around. The acquisition closes. A new holding company appears. Under it, the operating company keeps the license. Next to it, a management company invoices the operator for services. Above and around it, a web of limited liability companies controls the pieces. The landlord might be a related entity that now owns the building through a sale-leaseback. Rent becomes a fixed cost. Debt service becomes another. Every dollar of operating expense is reevaluated. Ownership becomes hard to see. Families search the government's database and find a tangle of names they don't recognize. Some firms aren't listed at all because the reporting categories don't require naming the fund itself. And issue watchdogs have documented with examples like the Porto Piccolo Group not appearing by name while its principals do in CMS data. A facility can appear independent when, in practice, it's part of a chain stitched together by affiliates and related parties. For an investor, this opacity is standard structuring. For a resident, it means the people who set staffing levels might be 3 entities away. On paper, the efficiencies look harmless. A small reduction in staffing hours per resident per day. A shift in mix, fewer registered nurses, more aides. Tighter formularies for medications and supplies. Centralized purchasing. A push to rely on agency staff when shifts can't be filled. Management fees for corporate services. Rent set to market, or a little above, because the building's value has been unlocked. Each change seems incremental. Together, they define the new baseline. Meanwhile, marketing stays warm. The 5-star rating hangs in the lobby. Tours still pass a common room that looks busy at 11 a.m. The activity board promises trivia at 2. But outcomes lag marketing. Residents don't know who owns the debt or who collects the rent. They know how long it takes to get help to the bathroom. The playbook depends on debt. Cheap borrowing multiplies equity returns. But interest isn't paid with excess time. It's paid with cash flow. The operator trims wherever regulators aren't immediately watching, and where penalties, if they arrive months later. Financial engineering does the rest. A buyout generates fees for the fund, interest for lenders, rent for the real estate entity, and synergies for the management company. The operator, the licensed entity responsible for care, carries the weight. Researchers later found that in PE-owned facilities, these pressures coincided with measurable care changes. Fewer paid nursing hours and more antipsychotic use, associated with worse outcomes. Why nursing homes and not another sector? Because the revenue is largely guaranteed by government programs. Funds call that stability. Owners can count the dollars. The costs, however, are borne by people who can't leave easily. A resident with advanced dementia doesn't comparison shop. A daughter juggling 2 jobs can't parse an ownership chart. When things go wrong, the consequences aren't missed deliveries or delayed software updates. They're bedsores, falls, infections, and too often funerals. It's not that every acquisition is predatory. Some homes need capital. Some owners keep standards high. Medicaid rates do lag costs in many states. Workforce shortages are real. But the structure of private equity accelerates the trade-offs. When a fund seeks annual returns of 20% or more, and the pathway is expense control and asset monetization, the pressure lands on the floor, on the people turning residents and passing meds. There's also the timing problem. A fund wants to exit in 3 to 5 years. The surest way to show growth in that window is to extract value up front. Sell the building, sign a long lease, refinance, distribute proceeds. That leaves the operator with higher fixed costs and thinner margins. If a pandemic or a staffing crisis hits, there's no cushion. Bankruptcies follow, and residents remain because they can't go home. By now, the spreadsheet has done its job. The roll-up looks efficient. Costs are down. Earnings are up. A buyer appears. The fund sells. On slide 1 of the deal deck, the line climbs. But across thousands of rooms, the call light still blinks, and the hallway is still quiet. The numbers don't feel the weight. People do. And after the buyouts, the outcomes changed. The mortality shock. Here's where the quiet math meets the quiet room. Researchers at Chicago Booth, NYU, and Penn pulled 15 years of Medicare and Medicaid data, more than 18,000 homes, from 2004 to 2019. They tracked what happened when private equity funds took over 1,700 of them. After the buyouts, short-term mortality rose about 10%. Not a rounding error. A measurable shift in life and death. Gupta, Howell, Yanalis, and Gupta, 2021. Translate that into people. More than 20,000 additional deaths over the period. Roughly 1,000 a year. That's a small town gone, spread across thousands of facilities, hidden in quarterly reports and sterile acronyms. What changed inside those walls? Staffing first. The team found an average 1.4% reduction in total staff after acquisitions, and about a 3% drop in paid nursing hours. On a spreadsheet, those percentages look minor. On a night shift, they mean 1 aide covering 2 hallways instead of 1. Turning residents every 2 hours becomes aspirational. Monitoring for infection slides. The MedPass stretches past dinner. Chicago Booth reviews summary of the study. Meanwhile, something else was happening. Antipsychotic use jumped by about 50% in the P-owned homes. These drugs can sedate residents with dementia, keeping them quieter, easier to manage with fewer hands. But conventional antipsychotics are associated with increased mortality in older, institutionalized patients with dementia. Less staffing plus more chemical restraint. That's the lethal combination the researchers point to. Chicago Booth Review. What nobody knew at the time, standing in those hallways, was how consistent the pattern would look at scale. The statistical approach compared similar residents across similar facilities, controlled for local trends, and isolated the timing of the takeover. The mortality bump lined up with the ownership change. The signal survived robustness checks. The conclusion didn't depend on one chain or one state. This was the moment everything changed in the data. Even if the lobby still smelled like lemon cleaner and the aquarium still bubbled near the front desk. The cuts weren't dramatic enough to trigger alarms overnight. They were friction. 10 minutes here, a skipped toileting there, a pressure ulcer that didn't need to happen, an aspiration pneumonia that should have been caught. Individually small, cumulatively fatal. From a resident's perspective, the difference shows up in micro-decisions. The fall that comes because the call light took 5 extra minutes. The UTI that turned septic because rounds were rushed and fluids were missed. The confusion after a new medication because there wasn't time to double-check a chart with the family. None of these moments make headlines. Together, they change survival curves. Families felt the drift before anyone published it. She's different, a son might say. Sleepy. Slower. Staff noticed too. A nurse quietly pulled aside a daughter and said, "We don't have the bodies." And yet, the records showed compliance boxes ticked, care plans signed, staffing ratios averaged over a week that hid the Saturday night void. Parallel to this, the business metrics looked fine. Expenses down. EBITDA up. Investor updates highlighted integration, procurement savings, labor efficiency. What they didn't write was that efficiency in a care setting often means there's less human attention, available when the unexpected happens. In geriatrics, the unexpected happens every hour. Now remember, this isn't a lab with a clean counterfactual. Some homes improved under new owners. Some residents would have declined regardless. Medicaid rates lag. COVID later magnified everything. But across thousands of cases, the mortality signal stayed. It didn't vanish when the researchers sliced the data different ways. It persisted when they accounted for case mix and geography. Here's where it gets uncomfortable. The mortality increase is short-term. That's a hint about mechanism. If ownership primarily changed long-run investments, like capital upgrades, you'd expect slower-moving effects. But trimming staff hours and upping antipsychotics shift risk quickly. They affect falls this week, infections this month, delirium tonight. While that was happening inside, families on the outside faced the opacity we saw earlier. They couldn't connect the outcome in a single room to a financing Model 5 LLCs away. They saw the obituary and a bill, not the rent covenant or the quarterly interest payment. Regulators didn't see it fast either. Survey cycles lag. Penalties arrive months later. Mortality isn't itemized on an invoice. The backlash started quietly in academic journals and policy briefs, then moved into hearings. If this is true, lawmakers asked, why are we spending more through Medicare while residents do worse? We'll come to the money. For now, sit with the human math. 1,000 extra deaths a year is roughly 3 each day. 3 families every day who could have had one more holiday, one more morning coffee, one more chance to say yes to the photo on the bedside table. The industry's defenders say ownership isn't destiny. They're right, but incentives nudge decisions, and decisions pile into outcomes. After the buyouts, the outcomes changed. That's not a theory. It's a record. Lower care, higher costs. If residents are worse off, why are the bills bigger? Because the costs don't disappear, they move. While Cornell researchers followed long-stay residents after private equity takeovers and saw something you can feel in an ER waiting room, more avoidable crises. Ambulatory care-sensitive visits to emergency rooms went up about 11%. Hospitalizations rose roughly 8.7%. Conditions that should be managed on the floor, fluid balance in heart failure, insulin timing in diabetes, antibiotics started before fever spikes, showed up downstream as emergencies. JAMA Health Forum, 2021. Meanwhile, Medicare paid the tab. The team found Medicare spending per resident was about 3.9% higher, roughly $1,080 more each year, compared with similar for-profit homes without private equity ownership. Add that across thousands of residents, and you're talking real public money. Inside the facility, the operator saves by trimming hours, shifting staff mix, tightening supplies. Outside, hospitals admit more residents, specialists bill more visits, ambulances run more calls. The savings inside are matched by spending outside. While Cornell Medicine summary. This is the cost shift dynamic. A facility can cut a nurse on nights and still pass a weekly staffing average. The missing eyes at 3 a.m. become an ER visit at 7 a.m. for aspiration or dehydration. The home's ledger looks cleaner, Medicare's doesn't. Families don't see an accounting transfer. They see their mother in a hallway bed under fluorescent lights waiting for a CT. When she's stabilized and sent back, the cycle repeats. Every transfer adds delirium risk, pressure injury risk, infection risk. Each transfer also bills Medicare. From the owner's perspective, the incentives line up. Most revenue is public, Medicaid for room and board, Medicare for post-acute and medical episodes. But the profit extraction, management fees, rent to related landlords, interest on acquisition debt, flows to private entities upstream. If hospitalizations rise, that's Medicare's problem, not the operators, unless penalties arrive quickly and bite hard. They usually don't. Get this, the numbers that look like efficiency in a quarterly update often show up as noise in a hospital budget. An extra day admitted for complications is invisible to the nursing home's P&L. An ambulance that didn't need to roll doesn't land on their expense line, but it lands somewhere. We all pay for that, through taxes and premiums. Here's where the micro decisions become macro spend. A resident with heart failure needs daily weights, careful diuretics, salt control, and someone to notice ankle swelling. cut paid nursing hours by a few percent, and those weight checks slip. 2 days later, shortness of breath, a blue pulse oximeter clip, a 911 call. In the ER, labs, imaging, a bed upstairs. The facility saved an hour of staff time. Medicare spent thousands. Or think about diabetes. Insulin isn't just a dose. It's timing with meals and monitoring for hypoglycemia. Rotate agency aides who don't know the resident's routine, compress the med pass because one nurse covers too many rooms and low blood sugar sneaks in. Confusion, a fall, a head CT, observation status that turns inpatient by midnight. The home's operating margin widens. The hospital's census grows. Medicare's check goes out. Families often feel like they're doing 2 jobs, caregiving and auditing. They bring snacks to keep calories up because mealtimes are rushed. They track meds because the faces change. They chase down care plans because turnovers blur responsibility. None of that shows up on a balance sheet. The only line item with a number is the ambulance bill. Meanwhile, policy fights circle overhead. Trade groups argue ownership isn't destiny, and they make real points. Medicaid rates lag costs in many states. Workforce shortages are painful. Rural homes face thin margins. All of that can be true, and the Weill Cornell pattern can still hold. After takeovers, avoidable ER visits went up, hospitalizations went up, and Medicare spending went up. The mismatch between who saves and who pays got wider. There's also the hidden tax of volatility. Every hospital transfer fragments care. Medication lists get rewritten, then rewritten again, and reconciliation errors creep in. Physical therapy progress resets because 3 days away means lost strength. Discharge planners hustle to find a bed back at the same facility, or any facility, because leases and landlords, not just clinical needs, shape placement. Each handoff adds cost. Owners will say they're optimizing within the rules. And they are. That's the point. If the rules let you shift risk to Medicare and still collect rent and fees, the spreadsheet will steer you there. A nurse knows that a second pair of hands at dinner prevents choking. A model knows that cutting 1 FTE improves EBITDA. Only one of those shows up in the deck. The irony is hard to miss. We're paying more to get less. Less attention, less continuity, less stability. Not because the nurses don't care, but because the structure rewards the absence of them. When emergencies become the plan, Medicare becomes the backstop. The residents pay with confusion and time. The rest of us pay with dollars. The extraction toolkit. To see how the money actually leaves the bedside, follow the tools. They're quiet, technical, and completely legal. Start with debt. The acquisition rarely uses cash, it uses leverage. Loans layered at the fund and at the operator push interest into the monthly budget. Interest doesn't wait for flu season to pass. It comes on the 1st every month, and it competes with hours on the floor. A don who needs another nurse on nights is suddenly negotiating against a covenant. Miss the coverage ratio, and lenders start calling. Hit it, and someone miles away collects a coupon clipped from the same dollars that used to buy wound care supplies. Then the building moves. Sale-Leaseback is the cleanest extraction in the kit. The new owners sell the property to a related landlord or a REIT, book the proceeds, and sign a long lease. Unlocking value sounds harmless until you read the rent schedule. Base rent rises with escalators. Triple net terms shift repairs and property taxes to the operator. What used to be a flexible asset becomes a fixed obligation. When census dips or wages spike, the rent doesn't care. The landlord still gets paid, often by the same principals wearing a different hat. Next comes the management company. It's separate from the operator, but the owners overlap. Corporate services, HR, IT, purchasing earn a monthly fee. On paper, that buys expertise and scale. In practice, it moves margin upstream, above the licensed entity that's responsible for care. Facilities also start buying from related vendors. Therapy companies, pharmacy groups, medical supply distributors that share ownership. Each invoice is at market. Each contract justified by a benchmark, yet the direction of flow is consistent. Cash migrates from the bedside to affiliates. Staffing shifts are the blunt instrument. Registered nurses cost more. Certified nursing assistants cost less. The ratio tilts. LPNs cover more med passes. RNs hold larger spans of control. Agency fills holes because churn rises. Agency costs more per hour, but it's variable. It can be cut next month to hit a target. Continuity, the thing that prevents subtle errors, is the collateral damage. Meanwhile, corporate targets trim paid hours by fractions that look benign in a deck and brutal on a double-loaded hallway. Here's where antipsychotics slide in. When hands are scarce, sedation masquerades as stability. These meds take the edge off agitation, quiet sundowning, and stretch staff farther than they should be stretched. Documentation often phrases it as behavioral symptoms, with checkboxes that satisfy audits. Families sign consent in a stack of papers. The downstream risk, falls, strokes, aspiration, lives in bodies, not spreadsheets. Regulators know the pattern. Enforcement lags anyway. Documentation becomes a game of inches. Plans of care are immaculate. Boxes are checked. Staffing averages meet the letter, while the Saturday night reality misses the spirit. Training modules get completed online. In-person coaching thins out. When a surveyor arrives, a borrowed nurse floats in from another building to cover lunch. The machine learns how to look compliant under pressure. The pressure never leaves. The toolkit scales through chains. A single facility can only squeeze so much. A network can centralize purchasing, share traveling administrators, rotate survey prep teams, and negotiate pharmacy rebates. That scale amplifies the extraction pathways. One landlord can hold dozens of buildings. One therapy affiliate can capture 1,000 daily billable minutes across a region. The retail face stays local. The financial guts are consolidated. Debt, rent, fees, related parties, each has a rationale. Each can be defended in a hearing. Each alone seems survivable. Together, they narrow the space where care lives. When something unexpected happens, a pandemic, a wage shock, a flu wave, the fixed costs don't bend. Operators default, chains reorganize, and landlords keep the walls. Residents don't get to pick which entity failed. They live with the fragility. From the perspective of a floor nurse, this toolkit shows up as fewer coworkers, more clipboards, and a weekly email about hours. The wound vac battery arrives late because the approved vendor had a backorder. The Hoyer lift is shared between units because capital requests are frozen. A new therapy company switches protocols, and the handoff costs a resident a week of progress. None of those moments look like extraction. They look like small frustrations. They add up to outcomes. Owners say this is modernization. Centralization reduces waste, they argue. Real estate separation raises capital for upgrades. Financial discipline prevents sloppy operators from drifting. Sometimes that's true. But when the discipline points in only one direction, upstream, and the risk points in the other, downstream, the balance breaks. If quality goes south, there's no automatic clawback from the landlord or the management company. The operator's balance sheet absorbs the hit. The upstream entities keep their rent and fees. Meanwhile, the public pays the overflow. Medicare reimburses the ER that catches the dehydration. Medicaid keeps the per diem flowing. Taxpayers fund the gap while beneficiaries live it. The toolkit wasn't built to hurt people. It was built to pull cash predictably. In a care business, that predictability competes with presence. And presence, watching, knowing, turning, comforting, is the one thing you can't lever. Who owns your parents' bed? Stand at the nurse's station and ask a simple question. Who owns this place? You'll get a license on the wall, a facility name on a badge, and maybe a local administrator's card. But the real answer lives in filings most families never see. Landlord LLCs, operating LLCs, a management company with the same mailing address as the landlord, and somewhere above them, a fund that doesn't appear on the front sign. Officially, the industry says private equity accounts for about 5% of nursing homes. Trade groups repeat it. Government sites echo it. It sounds reassuring, rare, marginal, an exception. But researchers and watchdogs who've tracked deals through state records and corporate disclosures say the 5% figure misses the quiet middle market. The Private Equity Stakeholder Project estimates the true share is likely closer to 13%, and the gap exists because ownership is hard to see by design, with complex structures and limited transparency in federal databases. While that was happening in Washington, new databases, new reporting rules, something else was happening across town. Smaller funds were buying clusters of facilities through layered entities, then operating them under local names. The Centers for Medicare and Medicaid Services launched an ownership database in 2022 to add transparency, but it often lists individual principals and affiliates without naming the firm that orchestrates the strategy. A family searching Porto Piccolo group won't find Porto Piccolo in many entries, even when its owners appear in the fine print, exactly the gap highlighted by watchdog reports. The effect is simple. The risk profile is hidden behind a mosaic of unfamiliar LLCs. This isn't just semantics or paperwork. Ownership shapes the bills a facility pays. Rent to a related landlord, fees to a management company, interest on acquisition debt. Those fixed obligations squeeze the line items that families feel. Staffing hours, supplies on the cart, overtime approvals. When a chain cuts paid nursing hours by a few percent across dozens of buildings, the change is invisible on a tour and obvious at midnight. Get this, official disclosures can be both accurate and misleading. The operator listed on the license does run the day-to-day, but a related real estate company may control the building, and a related service company may set budgets through management contracts. If the operator struggles, landlords and management affiliates still collect. And because each legal entity is separate, accountability scatters when harm is investigated. Fines land on the operator. The rent and fees keep flowing upstream. Families don't have time to decode this. They're comparing star ratings, reading a few reviews, walking a hallway for 20 minutes between work and picking up kids. CMS's star system helps, but it lags. Survey results arrive months after problems start. Ownership changes often don't show up for a while. If you ask about private equity, staff may genuinely not know because they work for the operator, not the fund. They know the schedule, not the capital stack. Meanwhile, the mid-market buyers keep moving. The stakeholder project flagged a steady trickle of deals after the big firms left the headlines. Firms you've never heard of taking over dozens of homes in a region. Cascade Capital Group's 2024 purchase in Iowa handed operations to its legacy arm right away, a tidy example of the split. One entity owns, another operates, a third manages. Genesis, once a public giant, took private capital as it delisted. In government data, a brand might stick, the capital behind it shifts. Here's where the human stakes show up. Choosing a home is already hard. Add opacity, and families are flying blind on the single factor that best predicts the pressures inside: how the owners get paid. A landlord owed rising rent has different priorities than a mission board reinvesting surplus. A fund on a 3-year clock leans on expense lines faster than an owner planning for 10. Residents live inside those incentives. Owners and trade groups argue it's a distraction to focus on private equity. They point to diverse ownership, nonprofits, mom-and-pop for-profits, regional chains, and they're right that Medicaid rates and workforce shortages hit everyone. But opacity isn't a side issue. It's the condition that lets extraction happen without scrutiny. If a facility's rent goes to a related party landlord at above-market terms, families can't see it. If management fees rise when care hours fall, nobody outside the corporate circle knows. What nobody mentions on the tour is the hold period. Investors rarely plan to keep facilities for a decade. The path to returns often runs through sale-leasebacks and leverage in the first few years. That's the window when the numbers look best, and the call lights wait the longest. When the exit comes, the sign out front might not change, but the bed you chose belongs to a new balance sheet with the same escalators and the same fees. So ask again, who owns your parents' bed? The name on the admission packet is one answer. The entities upstream, the landlord, the management company, the fund, are the answer that tells you what tomorrow's budget will protect first. Families deserve to see that clearly before they hand over a loved one's keys and a list of favorite snacks. Case file, roll UPS and ratings. To see the playbook in the wild, look at the chains whose names keep surfacing in filings and surveys. Not to single out villains, but to watch how structure meets outcome when the roll-up gets real. Genesis Healthcare was once the default name in post-acute care, big, everywhere, a known brand on the Care Compare site. As pressure mounted, it delisted from the stock market and took private capital, including a $50 million investment from Pinta Capital, to stabilize. The buildings? Many had already been separated from operations in earlier real estate deals. The result is a familiar stack. Operating licenses in one pocket, landlords in another, management services across the top. In the government's data, you still see Genesis, but the capital arrangements underneath are more intricate than the logo suggests. And in the ratings, the picture is uneven. Out of 219 Genesis-listed facilities, 73 sat at 1 star, bottom of the scale, when advocates pulled the numbers, as reported by the private equity stakeholder project. 1 star doesn't prove private equity caused anything. It signals where care struggled while financial engineering set the constraints. Now move to Iowa. In 2024, Cascade Capital Group bought one of the state's largest chains, 29 facilities, more than 2,300 skilled nursing beds, plus assisted living units, for about $85 million. Almost immediately, operations shifted to Legacy, Cascade's own management arm. That handoff is the split we keep seeing. Owners on one side, operators on the other, fees linking them. Private equity stakeholder project via McKnight's. Residents don't see a closing memo. They feel the downstream effect when budgets and protocols arrive from a management company that earns more when the operator improves efficiency. Survey histories in clusters like this often show the same pattern. Staffing hovering near the minimum, pressure injuries cited more often than they should be, corrective action plans that read like déjà vu bankruptcies tell the rest of the story. Levy Care Centers, formerly Consulate, entered bankruptcy under pressure from debt and rent obligations that outpaced thin margins. Gulf Coast Healthcare followed, its reorganization shaped by lease terms that didn't bend just because wages spiked and census dipped. In both cases, related party rents and acquisition leverage didn't disappear when care got harder. They hardened. Landlords protected their escalators. Lenders protected their covenants. Operators failed in the middle. Residents stayed in the same rooms while ownership pages flipped in court, documented in watchdog and trade press reporting. Inside these chains, staff describe versions of the same day. The scheduler texts at 5 a.m. because 2 CNAs called out. An agency aide arrives, kind but unfamiliar with Mrs. Alvarez's sundowning routine. The med pass stretches because LPNs cover more rooms. A wound vac dressing gets delayed because the approved vendor shorted a shipment and capital requests are paused. None of this shows up in a prospectus. It shows up as new citations for actual harm or immediate jeopardy when a pattern becomes an emergency. Meanwhile, ratings wobble. A facility can be 4 stars one quarter and 2 the next, not because the walls moved, but because staffing thresholds slipped or inspection findings landed after an ownership change. Roll-ups often bank on the lag. Make changes now, realize savings this quarter, and hope star penalties post later or can be managed by an improvement plan. When they do post, marketing points to ongoing remediation, and ownership, still opaque, rarely takes the headline blame. Look closely at related party lines in cost reports when they're available. Therapy switches from an independent provider to an in-house company with common ownership. Pharmacy services follow. Management fees tick up slightly, justified by scale. Rent to a related landlord rises on schedule. Each move is defensible in isolation. In aggregate, it drains the operating entity's room to choose dignity over throughput in a hard shift. Genesis's footprint shows how scale can insulate and expose. Centralization can get supplies to a hurricane zone, but it can also lock in procurement that prioritizes price over clinical fit. Legacy's rapid assumption of Iowa operations shows how fast the ownership-operator split can be installed, long before families understand who sets staffing. Levy and Gulf Coast show what happens when fixed obligations meet variable reality. You can't lever a nurse. Here's a micro-story from a rolled-up chain's night shift. The Don walks the floor at 10 p.m., counts heads, and realizes the ratio is 118 on the long-term unit. She calls the regional manager for approval to keep the agency aide, who just finished a double. The answer comes back, we're over hours. The Don stays, charts until 2 a.m., helps with turns, then starts again at 7. The next day, a surveyor arrives. The books show compliance on average. The hallway showed the truth last night. When case files stack, the pattern stops looking like anecdotes and starts looking like a business model. Ratings drop in clusters. Bankruptcies cluster where sale-leasebacks were aggressive. The same names recur in landlord entities and management contracts. And through it, residents live the arithmetic. Fewer stable hands, more sedation, more transfers. None of these chains invented frail margins or workforce shortages. But the roll-up amplified fragility with obligations that never sleep. Micro-stories from the floor. Ava started her 11 p.m. shift with a list. Turns every 2 hours on 6 residents flagged for skin risk. At 1 a.m., the call lights stacked. 1 fall alarm, 1 bathroom assist, 1 wanderer near the exit. By 3 a.m., she'd turned 4. Mr. Daniels didn't get his turn until 3:40. By morning rounds, a red spot on his hip looked angry. The wound nurse would call it stage 1. monitor and protect. Ava called it the 30 minutes she didn't have. Across the hall, Teresa ran the med cart. 27 residents on her pass, insulin windows tight, 2 antibiotics due, 1 antipsychotic added yesterday with a note. Increased agitation. Mrs. Bloom refused breakfast and looked drowsy. Teresa double-checked the MAR, then moved on because 3 cups of water and a crushed pill took 10 minutes she couldn't spare. At noon, Mrs. Bloom slid in her chair. The aide caught her. "She's different," the aide whispered. "She's on a new med," Teresa said. "I know," the aide answered. "I can feel it." An agency CNA named Paul covered 2 wings that night. He didn't know the families, the nicknames, the tells. He learned fast. Mr. Ortiz needs a sweater to settle. Miss June likes her tea before bed. Mr. Lee will say yes to anything if you smile. But when Miss June's daughter called to remind staff about her mother's swallowing issues, Paul nodded politely and wrote nothing down because he didn't have a login for the chart. At 2 a.m., Miss June coughed through applesauce, tired and irritated. Paul looked for thickener. The pantry was out. Families brought their own supplies. Gloves when the box went empty at 8 p.m., briefs that didn't chafe, snacks to coax calories. Marcus, whose father hated the taste of the house protein shakes, blended his own in the car and labeled them with a Sharpie. He left notes on the fridge. "Please offer at 3 p.m. He'll say no. Try again at 3:10. Staff tried, when they could, and thanked him for making it easier. He checked the waste bin each night to see if the bottles were still full. Some nights they were. A call light blinked in room 214. 10 minutes passed. Then 12. The daughter started counting under her breath. At 15, she walked to the desk. "He's wet," she said, apologetic and annoyed. "I know," said the nurse, not defensive, just tired. "We don't have the bodies." She said it softly, like a confession and a warning. The daughter nodded. She started carrying a stopwatch and a notebook. 14 minutes at breakfast, she wrote one day. 22 at bedtime. She showed it to the administrator, who promised to review staffing. The patterns didn't change. On Tuesday, the activity board still promised bingo at 3. At 3, a maintenance man wheeled the cage of laundry down the hall. The activity director apologized, playing music from her phone to fill the quiet. "Tomorrow," she said. Mrs. Hendricks smiled anyway, because the music was Elvis. Micro-wins counted. Micro-failures did too. A night nurse kept a stash of heel protectors in her locker because the order never arrived on time. She cut foam into makeshift wedges for ankles that were starting to pink. She taught an aide to float heels with pillows, like this, one on each side, so they don't roll. She wrote it in the care plan and showed the daughter how to check. The daughter took a picture and sent it to her siblings. Ask about her heels. On Friday, a new admission came from the hospital. Discharge summary: heart failure, diabetes, dementia, new antipsychotic. The hospital added it because he pulled at his 4. The nurse read the line twice, frowned, and circled it. "We'll need consent," she said. The son signed because it was in a stack, and the nurse had 6 more signatures to get. The next morning, his father slept through breakfast and missed his diuretic. By Sunday, his ankles were tight, his breath shallow, and the hallway echoed with the squeak of the stretcher wheels. An aide named Lila clocked out late to sit with Mrs. Price, who cried when the sun went down. Lila held her hand and hummed, "You are my sunshine," and Mrs. Price stopped crying for 3 minutes. Lila cried in her car at 12:15 because she'd missed her bus and owed 2 hours of overtime she wouldn't be approved to claim. On Monday, she told the scheduler she couldn't cover next weekend. "We're short," the scheduler said. "Every weekend," Lila said back. "These aren't headlines. They're the quiet ledger of a building. Every delay has a reason: sick calls, broken lifts, a delivery that didn't arrive, a budget that didn't bend. Every fix has a person in it: a nurse with heel protectors, a daughter with a stopwatch, a son with protein shakes. Meanwhile, upstream, rent posted, fees cleared, interest accrued. Downstairs, it still took 14 minutes to answer a light at breakfast. And at midnight, Ava still had 2 more turns before she could sit. Regulation that can't see. Oversight exists, but it moves on a delay. A resident is harmed on a Tuesday. The state survey happens weeks later. The citation posts months after that. By then, the staffing spreadsheet has already been recut and the management fee already paid. Families read deficiency corrected long after the wound has healed or the funeral has passed. The guardians of quality are split. States send surveyors for on-site inspections. The federal government runs care compare star ratings and sets payment rules. But fragmentation means accountability gets diluted. A state might flag falls and dehydration at one address, while a federal database still shows 4 stars because staffing averages from last quarter haven't updated. Meanwhile, corporate offices know exactly what was spent yesterday and where the hours fell short. Ownership transparency was supposed to help. CMS launched an ownership database in 2022 to make the web of landlords and operators visible. It helped, but only to a point. Many entries list individual principals while omitting the private equity firm's name entirely. A chain tied to a mid-market fund can look like a scatter of small operators. Reporters and watchdogs can trace the connections, a family cannot. Even regulators struggle when names change without flagging the controlling relationships. Related party transactions hide in plain sight. A facility reports rent, management fees, therapy, and pharmacy costs. Each looks normal at the surface. But if the landlord and the therapy company share owners with the operator, money moves in circles that oversight doesn't fully map. When surveyors cite poor care, penalties land on the licensed operator. The affiliates upstream, collecting rent and fees, aren't automatically pulled into the conversation, even when their terms helped starve the floor. Staffing rules have whiplash. Minimums rise in one administration, then stall or get rolled back in another. Trade groups argue that mandates without funding will force closures, and states underpay Medicaid in many places. That's real. But in the absence of clear, enforced floors tied to payer rates, staffing becomes a dial owners turn to hit margins. Averages over a week can mask the reality at 11 p.m. on a Saturday when one aide covers 2 halls. The spreadsheet meets the letter. The hallway misses the spirit. Documentation smooths the edges. Care plans are immaculate. Training modules are completed. Policies are updated with the right verbs. When surveyors arrive, extra hands appear, borrowed from a sister facility or pulled from agency for the day. The snapshot looks better than the movie. By the time the written report lands, leadership has rotated, the dawn has changed, and the corrective action plan reads like the last one: promises to monitor, to educate, to audit. Enforcement doesn't scale with harm. Fines can be negotiated down. Payment denials sting, but they're often temporary. There's no standard mechanism that claws back rent or management fees when outcomes degrade. The operator eats the penalty while the related landlord still collects. In bankruptcy, landlords and lenders line up with contracts in hand. Residents stay in place, survivors of an accounting. Politically, reforms drift. Transparency rules inch forward, then pause. Proposed staffing floors meet pushback and lawsuits. Meanwhile, researchers keep finding the same patterns. After private equity takeovers, short-term mortality up roughly 10%, Chicago Booth, NYU Penn. Antipsychotic use up, same study. Avoidable ER visits and hospitalizations up, Medicare spending per resident up about 3.9%, roughly $1,080 annually, while Cornell. The numbers sit in journals while families sit in waiting rooms. Surveyors are often outnumbered by the problems they're sent to find. Many are nurses who know exactly what safe care looks like, but their caseloads are heavy and their tool is a checklist. They can cite and fine. They can't rewrite a lease that escalates rent faster than payer rates. They can't pierce the veil to hold a fund's partners to account. The authority stops at the operator's boundary. The money flows past it. Here's the quiet irony. The system produces ratings that imply comparability, yet it can't reliably tell you who really owns the risk. A facility's star can fall for reasons that trace back to a landlord's terms or a debt covenant, but the database won't say that. Families choose based on stars and a tour. They rarely see a red flag that says, rent to a related party is high, management fees rose last year, clinical hours fell. Owners say they comply with every rule. Often they do. That's the point. The rules don't see fast enough, deep enough, or high enough upstream. Harm happens in minutes. Regulation reacts in months. Extraction happens through contracts that regulation rarely touches. Until oversight connects quality outcomes to financial structures and attaches consequences to the entities extracting cash, the incentives will keep steering away from the bedside. The call light will keep blinking while the system logs another compliance training completed. The industry's counterargument. From their perspective, the hallway stories miss the bigger picture. Trade groups like the American Health Care Association and Leading Age start with a baseline. Private equity isn't the norm, they say, roughly 5% of facilities by official counts. Owners are a mixed bag: nonprofits, family-run for-profits, regional chains, hospital systems. Point to a failing building, and you might be pointing at any of them. Meanwhile, they argue, the sector is underfunded and short-staffed, and that's been true for years. They lead with Medicaid. In many states, the daily rate doesn't cover the actual cost of care. If you're losing money on every long-stay resident paid by Medicaid, and most beds are, something else has to make up the difference. Historically, that's been Medicare-paid post-acute rehab days, managed care add-ons, or private pay residents. When those cushions thin, the math turns brutal. Under that math, the line between efficiency and cutting corners starts to blur. They point to workforce. The pandemic knocked thousands of nurses and aides out of the field. Burnout rose. Wages climbed in other service sectors. Even when owners raise pay, they can't conjure RNs in rural counties with one high school and no nursing program within 70 miles. Agency fills gaps. That's not a strategy, they say. It's a survival tactic when the labor market is bare. A Saturday night with one aide covering 2 halls isn't always a budget choice. Sometimes it's the only person who said yes. They argue that focusing on private equity distracts from the broader crisis. They talk about rural closures where the nearest alternative is 40 miles away, and families don't have a second option. They remind lawmakers that hospitals push patients out faster, sicker, and the acuity on intake today is not what it was a decade ago. They ask for higher Medicaid rates tied to inflation and acuity, help with training pipelines, and immigration policy that recognizes chronic shortages in elder care. There are fair points here. Medicaid rates do lag costs in many states. Workforce shortages are real. The pandemic was a shock that exposed and worsened everything. Blaming a single ownership class for 1,000 separate frictions oversimplifies a messy system. Even the strongest critics acknowledge that good and bad care exist across ownership types. But then they hit the studies, and the tone shifts. Industry representatives question methodology. They ask whether the Weill Cornell team accounted for local hospital practice patterns that might inflate admissions. They wonder if the Chicago Booth analysis captured unobserved differences in case mix. Facilities bought by funds might already be on a downward slope. They note that private equity is a broad category, from megafunds to mid-market buyers, and outcomes may vary. Researchers anticipated most of that. The Chicago Booth NYU Penn team compared similar residents across similar facilities, controlled for local trends, and timed the mortality increase to the buyout. The 10% rise in short-term mortality, the 20,000 excess deaths over the study window, persisted through robustness checks. The Weill Cornell analysis matched private equity-owned homes to other for-profit homes and still found 11% more avoidable ER visits, 8.7% more hospitalizations, and about 3.9% higher Medicare spending per resident, roughly $1,080 a year. These aren't one-off anecdotes, they're consistent patterns across thousands of beds. Trade groups respond with a different number. They say the 5% share of PE ownership makes it statistically noisy to generalize. Watchdogs counter that the denominator is wrong. Complex structures obscure true control, and the share is closer to 13%. Even if you split the difference, it's not trivial. And the mechanism, staffing cuts of roughly 1.4%, about a 3% drop in paid nursing hours, a roughly 50% surge in antipsychotic use, Chicago Booth and Penn, isn't a vague correlation. It describes choices that show up at the bedside quickly. Owners say sale-leasebacks unlock capital for upgrades. Sometimes they do. But lease escalators don't pause for wage spikes, and rent set by a related landlord isn't neutral when payer rates lag. Owners say management companies bring expertise. Sometimes they do. But related party fees that rise while clinical hours fall look less like expertise and more like extraction when residents decline. The most persuasive defense comes from people trying to run buildings well inside these constraints. Administrators who beg for higher rates and fight to keep staff. Dons who stretch to cover shifts and still coach new aides. They're not villains, they're buffers. Their plea to policymakers is simple. If you want better staffing, fund it and enforce it fairly across ownership types. If you want transparency, build a database that actually names controlling entities. If you want to stop harmful arbitrage, Tie financial structures to quality outcomes so rent and fees share downside when residents suffer. That's the bridge between the counterargument and the data. It's possible to hold two truths. System-wide underfunding and shortages are real, and private equity's incentives have made outcomes worse where they've taken hold. One truth doesn't cancel the other. The question is design. If the rules let owners profit when care degrades and shift costs to Medicare, then even good actors swim against the current. Change the current, and the best operators, whatever their ownership, can prove it in the hallways, not just the decks. Policies that could matter. If the incentives are wrong, fix the wiring. Not with slogans, but with rules that move money when care moves. Start with sunlight. Families need to know who's upstream, real beneficial owners, not just licensees and mailing addresses. Build a public dashboard that names controlling entities, flags related party landlords, and discloses management and therapy affiliates. Require standardized ownership charts on admission packets. When an owner changes, push a real-time alert to Care Compare. If a landlord is related, show rent and escalators next to staffing hours so people can see what squeezes what. Transparency isn't enough without guardrails. Set financial boundaries that keep cash close to care. Prohibit debt-funded dividends for a period after acquisition. Cap sale-leaseback rent relative to payer rates and case mix, with escalators tied to public funding, not arbitrary CPI plus formulas. If rent flows to a related party, require a certified independent valuation and publish it. Make management fees to affiliates subject to fair value reviews and disclose them quarterly. It won't stop every abuse, but it will make extraction visible and contestable. Approval needs teeth. Treat nursing home M&A more like hospital mergers. Require state attorney general or health department approval for change of ownership, with fit and proper person tests for controlling individuals and funds. Review prior quality records across all entities they've owned, not just the acquisition target. Consider cumulative effects when chains grow in a region. If an operator's affiliates were tied to repeated immediate jeopardy, citations, or bankruptcies that shed obligations, that should weigh heavily. Approvals can carry conditions, minimum liquidity, caps on related party transactions, and triggers that stop fee flows when quality drops. Then fund staffing and lock it in. Set staffing floors that reflect acuity, not a blunt ratio, and link them to payer rates. If Medicaid is the dominant payer, increase rates with guardrails. Dollars earmarked for clinical wages and benefits, audited quarterly. Publish turnover, vacancy, and agency reliance on the same dashboard as ownership. Create a staffing stabilization pool, time-limited grants to rebuild core teams, tied to measurable reductions in agency hours and improvements in continuity-sensitive metrics like pressure injury rates. Pay for outcomes with real downside. Move beyond symbolic star tweaks. Create quality withhold pools meaningful enough to matter, funded by a small per diem holdback, returned only when facilities hit benchmarks on avoidable hospitalizations, antipsychotic use, pressure injuries, and family-reported responsiveness. If outcomes degrade, the withheld funds get redistributed to facilities that improved or to regional workforce pipelines. Couple this with rapid cycle feedback, monthly not annual, reporting on sentinel measures so course corrections aren't a year late, mirroring the very outcomes highlighted by the Weill Cornell and Chicago Booth NYU Penn findings. Clawbacks should follow harm upstream. When a facility enters immediate jeopardy or shows sustained declines, automatically pause payments to related party management affiliates above a threshold, pending a corrective plan. If public funds increase during a crisis, restrict their use to operations and capital that touches care. No rent increases to affiliates during the emergency window. If a chain goes bankrupt, empower receivers to renegotiate leases with related landlords and recover excessive fees paid within a look-back period. We also need emergency brakes. Create automatic ownership flags. When CMS detects spikes in antipsychotic starts or avoidable hospitalizations or sudden drops in clinical hours, a temporary oversight status triggers, more frequent surveys, mandatory technical assistance, and spending restrictions that prioritize staffing and essential supplies. The flag should follow controlling owners across states. A fund with multiple flagged facilities faces heightened scrutiny on new acquisitions. Data should work for families, not just auditors. Post simple, comparable metrics. Average call light response time, night shift staffing by role, percent of hours by agency antipsychotic. Initiation rates with consent documentation rates, hospital transfer rates for ambulatory care-sensitive conditions. Let people sort by these, not just stars. Require facilities to disclose, in plain language, who the landlord is, whether it's related, what the rent is per bed, and how much was spent on capital improvements last year. Support the workforce like a core infrastructure. Fund paid clinical ladders for CNAs to become LPNs and RNs, with bonded stipends that keep graduates local. Provide tax credits or enhanced rates for facilities that hit multi-year retention targets, verified independently. Pair this with predictable immigration pathways for experienced long-term care workers, so we can't hire stops being a permanent excuse. Finally, align the hospital nursing home seam. Share savings models can work if designed tightly. When avoidable hospitalizations fall, split Medicare savings with facilities that proved it by staffing up and keeping residents stable. But tie savings to measures that can't be gamed and publish the contracts. If an owner cuts floors and transfers costs to Medicare, they shouldn't share savings anywhere. They should face escalating penalties and public flags that follow their name, because the data show those cuts coincide with higher ER visits, hospitalizations, and Medicare spending. None of this is magic. It's plumbing. Put the pressure where the harm begins, upstream in contracts and incentives, and relief where safety lives. A second pair of hands at 11 p.m., a nurse with time to notice swollen ankles, a care plan that isn't just a document, but a promise kept on a Tuesday. Choosing a home in a hidden market. You don't get months to learn a market. You get a hospital discharge date and a list of addresses. So start with what you can verify fast, then push for what they won't volunteer. Begin with ownership. Pull the facility on Medicare's Care Compare, then click through to the Ownership tab. Note the legal operator's name, then search your state's corporate filings for that LLC. You're looking for other entities tied to the same principles, especially a landlord LLC and a management company sharing an address. If the landlord is related, ask for the lease terms in plain language. Base rent per bed, annual escalator, who pays taxes and repairs. They might hesitate. Ask anyway. Rent that climbs faster than public rates will come out of staffing. Next, ask for names. Who is the beneficial owner above the operator? If they won't say, ask who signs the management agreement and who sits on the board. Write the names down. Then ask if the therapy, pharmacy, staffing agency, or medical supply vendors are related parties. If yes, ask for copies of the contracts, or at least the fee schedules and termination clauses. Related party money flows are where efficiency turns into extraction. Now walk the floor with a clock. Check the assignment sheet. How many residents per CNA right now, not on average? Ask to see the next 2 night shift schedules, weekends included, and count licensed staff by role. Ask for turnover rates for RNs, LPNs, and CNAs over the last 12 months, and the percentage of hours covered by agency. High turnover with high agency reliance means fragments of care and missed details. Ask specifically, how many full-time CNAs are assigned to my unit most nights? Get a number, not a smile. Ask about med management. What's the process to start, review, and to prescribe antipsychotics? Who gets consent, and how often are trials of reduction attempted? Request the facility's current antipsychotic use rate for long-stay residents, excluding those with schizophrenia diagnoses. Compare it to the state average. Then ask who audits diagnoses added after admission, and how frequently they review for accuracy. If they talk around it, that's your signal. Survey history matters. Pull 3 years of state inspection reports and read the narrative, not just the tags. Look for patterns: pressure injuries, dehydration, elopement, medication errors. Ask what corrective actions were taken and to show you evidence: training rosters, change policies, new equipment receipts. If all you hear is education provided, press for staffing adjustments tied to the fix. Policies don't turn residents, people do. Follow the money inside the building. Ask for last year's capital spending list, real items. Lifts, mattresses, call light systems, negative pressure wound therapy units. If capital is planned, ask what's already approved and when it arrives. Then look at basic stock: gloves full in the evening, boosters and briefs that fit, thickener on every unit. These are small but telling. Ask about call light response times and how they're tracked. Some facilities log button press to response digitally. If they don't, ask how the dawn knows when nights slip. Ask to see last month's quality dashboard. Falls with injury, hospital transfers for ambulatory care-sensitive conditions, new pressure injuries, and antipsychotic starts. You're not auditing. You're signaling that numbers, not tours, will guide your choice. Talk to staff without a manager hovering. Ask a CNA what would make their shift safer. If the answer is another pair of hands or working lifts, you're hearing the truth. Ask a nurse how many residents they med pass on nights, and whether they regularly get help with turns. Watch their face more than their words. Ask about family councils. Is there one? When do they meet? Can you attend before admission? Councils with teeth can escalate issues faster than lone voices. If there's no council, ask how administration gathers family feedback and what changed last quarter because of it. If the operator hedges on ownership, pivot to conditions. If rent is related party, will you disclose the rate? If no, note it. If management is related party, how do we know fees won't rise while staffing falls? You're surfacing incentive conflicts they'd rather keep abstract. Bring a one-page checklist. Ownership and landlord names. Related party vendors. Rent terms. Staffing on the unit at night and weekends. Turnover and agency percentage. Antipsychotic rate and consent process. Survey patterns and documented fixes. Capital spending delivered, not promised. Call light tracking. Family council. Then choose with your eyes open. A nonprofit can run thin. A for-profit can be excellent. A PE-owned facility can be stable under a careful operator. But when ownership hides, rents escalate, fees flow to affiliates, agency fills nights, and antipsychotics creep up, you're betting against time. If you have to choose that building because location is destiny, counter the risk. Visit often at off hours. Bring small supplies that prevent downward spirals. Keep a notebook on response times and wait trends. And build relationships with the people who actually keep your parents safe. You can't rewrite a lease. You can catch a pressure spot on day 1 instead of day 9. In a hidden market, vigilance becomes policy. Your questions don't fix incentives, but they change how a Tuesday goes in your parents' room. That's the scale you control. Why care became an asset class. To see why this sector drew financiers, start with the one thing Wall Street loves: certainty. Long-term care has a steady stream of residents fueled by demographics. The aging boom isn't a forecast, it's a calendar. The payers are mostly public: Medicaid for room and board, Medicare for hospital trips and post-acute care. Demand doesn't vanish in a downturn. Revenues may be thin, but they're regular. 4 funds underwriting risk, that's gravity. Then there's the split personality of the business: operations and real estate. A single nursing home isn't just a care team. It's a building with land underneath and fixtures on top. Financial engineering sees 2 assets where families see one. If you separate the walls from the work, you can borrow against the property, sell it, lease it back, and turn bricks into cash while the beds stay full. That dual stream, rent for one entity, operating cash flow for another, creates multiple levers for returns. Private equity also thrives on fragmentation. Thousands of facilities, many small, many independent, unevenly managed. That means roll-ups by a cluster, centralized purchasing, standardized billing, swap vendors to related parties, and claim scale. With cheap debt, you can pay yesterday's owner, layer loans, and aim for a 3 to 5 year hold. The model promises professionalization to sellers and synergies to investors. The returns come from spread, the gap between the cost of capital and the dollars you extract. Now remember the incentives. Fund managers are paid to deliver high internal rates of return on short timelines. In a sector where prices are regulated and margins are thin, there aren't many knobs to twist. You can add census, pull on payer mix, tighten costs, monetize the real estate, and push fees upstream. Every knob that moves quickly is closer to the bedside than anyone wants to admit. Staffing is variable. Supplies are variable. Rent and interest are not. Medicare and Medicaid turn the moral hazard dial. Public programs set rates and pay most of the bill. If an operator cuts hours and more residents land in the hospital, Medicare spends more. The facility doesn't reimburse Medicare for that ambulance ride. Unless penalties bite fast, the operator's savings aren't offset by the system's costs. Profits are privatized, the spillover is socialized. That's not a slogan, it's the architecture of separate budgets. The sector's low variance suits lenders. Predictable per diems are collateral. Even when census dips, Medicaid continues. That reliability supports leverage. Leverage magnifies outcomes. If operations improve, equity multiples rise fast. If operations don't, debt service still arrives on the first. The pressure doesn't land in a spreadsheet cell, it lands on a staffing grid. Real estate investment trusts added a ready buyer for walls. A sale-leaseback moves capital today and locks obligations tomorrow. Escalators in leases promise growth without expansion. Triple net terms shift risk to operators. If wages rise or acuity increases, the landlord still collects. The landlord can be independent or related. Either way, rent becomes a fixed priority that care has to work around. Meanwhile, mid-market funds saw an opening when big names exited headlines. Smaller deals attract less attention. State approvals are lighter. CMS's ownership database names people, not often the firms. A roll-up of 20 or 30 homes can happen under local brands with corporate structure that looks like alphabet soup. Families don't parse it. Banks do. Cheap money mattered. For a decade plus, interest rates sat low. Debt-funded dividends, recapitalizations, and aggressive lease terms penciled. When rates climbed, the math tightened, but the obligations remained. Operators squeezed labor and supplies to keep ratios green. Upstream entities, landlords and management companies, kept extracting on schedule. All of this sounds clinical until you translate it. The moment elder care became an asset class, the yardstick shifted. EBITDA replaced time at the bedside as the unit of improvement. The quarterly update replaced the weekly staffing huddle as the center of gravity. You can be a conscientious operator inside that frame, and many are. But the frame still leans toward extraction first, adjustment later. There's another draw. Coding and compliance games offer margin without overt rate hikes. Antipsychotics, documented as behavioral management, can stretch scarce staff. Therapy minutes, when paid fee-for-service, used to be a lever. Bundled payments changed it, but related vendors still capture slices. Purchasing at scale squeezes pennies per glove, harmless until stockouts delay care. Each move has a defense. Together, they stack. Investors point to modernization, centralized HR, better analytics, streamlined back office. Those can help. But when the core expense is people noticing subtle clinical changes, efficiency hits a wall. You can't improve outcomes by replacing relationships with dashboards. The business tolerates variance poorly because bodies don't buffer shocks the way warehouses do. So, why did care become an asset class? Because it offered stable demand, public payers, separable real estate, scalable fragmentation, and levers that moved quickly under debt. The returns looked routine, the risks looked remote, and the consequences were borne by someone else. That's not an indictment of finance as a tool. It's a reminder that the tool will optimize whatever you pay it to optimize. When the metric is yield, the model finds it. When the metric is dignity, you fund time. The past 2 decades told us which metric won. Reframing value in care. If the system keeps paying for the wrong thing, it'll keep getting the wrong result. So start by changing what counts. Value in elder care isn't EBITDA. It's whether a resident stays stable, oriented, and comfortable in the place they live. It's time. Time to notice swelling before lungs fill. Time to offer water twice when the first no is just fatigue. Time to sit during sundowning instead of reaching for sedation. If dollars don't buy that time, they're pointed the wrong way. Redefining value means measuring outcomes that track dignity. Look at avoidable hospitalizations, new pressure injuries, antipsychotic initiations without clear indications, and family-reported responsiveness. Post these monthly, not annually, and weight them more heavily than abstract process boxes. If a facility keeps residents out of ERs and off chemical restraints while preventing skin breakdown, that's value. Fund it like it's gold. Aligning incentives starts with teeth. Pay for quality can't be a bonus stapled to the back of a check. It needs real downside. Hold back a slice of payments and return it only when outcomes improve. If outcomes slip, move that slice to operators who proved stability. Tie staffing dollars to acuity and require that a defined share lands in bedside wages and benefits. Audit it, post it, and make the audit as routine as payroll. Transparency should be the default. Families should see the full ownership chart as easily as they see a menu. Related party rent. Show the rate and escalator. Management fees to affiliates. Show the percentage and the services delivered. If fees rise while clinical hours fall, that should trigger an automatic review. Hiding the ball isn't neutral. It's an advantage for those who extract fastest. We also need models built for care first, finance second. Mission-driven operators exist: county homes, religious nonprofits, community trusts that reinvest surplus in staff and capital rather than siphoning it off. Public-private hybrids can work when states backstop wages and demand outcomes, not just reports. Community ownership, co-ops where workers and families hold stakes, may sound idealistic, but it hardwires accountability. When you own the hallway, you fight to staff it. The data gave us a short list of leading indicators worth paying for. Staffing hours by role, not just totals. RNs matter for assessment, LPNs for med safety, CNAs for eyes and hands. Turnover and agency reliance. Continuity predicts fewer mistakes. Antipsychotic use, a real-time signal of strain that should fall when staffing stabilizes. Avoidable transfers, a litmus test for whether the building can manage what it should. Put money on these and pull money when they wobble. There's a cultural shift embedded in this. Administrators and dons shouldn't spend their best hours crafting compliance narratives. They should be recruiting, mentoring, and rounding with purpose. Give them budget authority linked to outcomes, not just volume. Reward the act of saying, "We're short on nights. We're raising the ratio and taking a margin hit until pressure injuries drop." Right now, that honesty is punished. Flip it so it's celebrated and funded. Owners upstream shouldn't be ghosts. If a landlord is related, its returns should flex with outcomes. Build clauses that reduce rent a notch when quality flags, restored when benchmarks recover. If a management affiliate extracts a percentage, tie that percentage to improvement, with clawbacks when residents decline. Make the capital stack feel what the hallway feels. Regulators can move faster without becoming sledgehammers. Sentinel alerts, spikes in antipsychotic starts, night shift staffing dips, transfer surges, should trigger rapid technical assistance and temporary spending rules that prioritize staffing and stock. Publish the flag so families know help is on the way and the eyes are on the right place. Let good operators opt into higher transparency for rate bumps, proving a path that others can follow voluntarily. And then, back to the bed. Reframing value isn't a white paper. It's what shows up when a daughter presses a call light. If someone answers in under 5 minutes, if her mother is turned on schedule, if the med pass is paced by a nurse who knows her. Baseline, the system is working. If that's happening, the totals on a spreadsheet will show it later. Pay for the minutes that make those moments, because in this business, minutes are medicine. We learned what not to fund: extraction that doesn't flex, opacity that hides, averages that mask nights. Fund the inverse. Fund presence, continuity, and clarity. The economics will follow the humanity if we let them. And the people we love will feel it first, long before a quarterly deck catches up. What we choose to reward. When finance outruns care, residents lose days they can't get back, and the bill lands in our taxes and premiums. If this changed how you see the hallway behind the brochure, watch our deep dive on Wall Street's farmland bet. The same incentives, different harvest. Subscribe for more true stories about money and power, and share this with someone choosing a nursing home today.